Hi, I'm Dr. Ron Berkman. Today we'll be discussing selective clinical challenges in contraceptive care. And upon reviewing the videos that we'll be showing during the various presentations, as well as reviewing the assigned readings and followed by the discussion session, participants should be able to discuss the risk of breast cancer with various contraceptive approaches, what contraceptive methods are appropriate for women with headache, the risk of venous thromboembolism with the use of various contraceptive approaches, what contraceptive methods are appropriate for obese women, and what are the risks and benefits of various forms of emergency contraception. In addition, we will review what some of the appropriate contraceptive choices are for women with various pre-existing medical conditions. This video will focus on what's written here in the yellow, that is the risk of breast cancer, and what should be used for women who experience headache, particularly migraine headache. So, what about hormonal contraception and the risk of breast cancer? There are major topics that one can focus on, and these are the ones that I've chosen that I think are important. Does the use of oral contraceptives, or any combination hormonal contraceptive for that matter, increase the risk of breast cancer? Does the presence of a BRCA mutation change the risk, particularly among oral contraceptive users? And does the use of progestin-only contraception or the levonorgestrel-releasing IUD increase the risk of breast cancer? Now, it's important to recognize that there are a lot of factors that go into the development of breast cancer. There's genetic factors, including repressor genes, proto-oncogenes, a number of growth factors, which include hormones such as estrogen and progesterone, and growth factors, even insulin, and there's tissue factors related to the basement membranes, related to various types of immune shielding, and angiogenesis. So the ability to tease out how a particular factor such as taking of an oral contraceptive or using some sort of hormonal preparation is difficult when there are this multitude of factors that go into the genesis of a breast cancer. The other thing that's important to keep in mind is there is a prolonged time course for most breast cancers to develop. From the time, and we'll look primarily here at the solid line, from the time that the first cell starts becoming abnormal all the way to preclinical, which is about almost 7 years, to when you can diagnose it, which is 9 years. This is a significant period of time for the tumor to progress, such that it would require an exposure basically a decade before you diagnose the breast cancer for it to be a factor in a particular patient's breast cancer. So that, for example, medications that are available today that have just come on the market, let's say in the last 2 or 3 years, probably are not factored in to current rates of breast cancer or current concerns about etiologic factors of breast cancer. Now, when you look at oral contraceptives and breast cancers, there's been a number of large studies that have examined this issue. One of the biggest, earliest studies, published in 1996, was a meta-analysis of 54 different studies that included over 53,000 women with breast cancer and over 100,000 controls. And their bottom line was that there was evidence that would suggest that oral contraceptive users aged less than 35 years had a slightly higher risk of being diagnosed with breast cancer than non-users, again a relative risk of about 1.24, but the risk declined over time for past users. By age 50, the cumulative risk of breast cancer diagnosis, in fact, was the same among OC users as well as non-users. And it also showed evidence that there was no reason to suspect that oral contraceptives, even higher dose oral contraceptives, increased the risk of breast cancer even with increasing duration of use. That is, did not show a duration effect. And there was no evidence that family history seemed to modify the risk among OC users. Finally, a lot of these results, because again, it was just a small increase, could be due to detection bias. That means that women who are using birth control pills or the like are seeing the doctor more frequently, such that they undergo more frequent breast exams, and again the diagnosis is made more frequently. Or it may be oral contraceptives could promote growth of some pre-existing tumors that were already there. Again, this business of the 9-year time frame from start to diagnosis. Another study, which came out a few years later in 2002, was a large case control study funded by NIH and the CDC. And this included over 4,500 cases of invasive breast cancer and over 4,600 controls, which were population-based controls. And all of these individuals were interviewed. The breast cancer cases were from the so-called SEER cancer registries. The women were aged 35 to 64, and the data was collected between 1994 and 1998. Overall, about 77% of the cases and 79% of the controls had used oral contraceptives. So it was in a group of women, obviously, that had experience with this particular form of birth control. What they did determine, however, that there was no risk of breast cancer in women who had ever used any type of oral contraceptive. Again, a relative risk of 0.9. And among women aged 35 to 64, current or former OC use was not associated with an increase of breast cancer risk. So again, a pretty negative study. Further, there was no increase in risk for longer periods of use or higher doses of estrogen. That is, there was no real duration effect. And the initiation of oral contraceptive use at a young age was not associated with increased risk, since there have been 1 or 2 case control studies prior to this study that suggested maybe initiating use at a young age increased the risk. Finally, family history of breast cancer was not associated with increased risk. In another meta-analysis by the AAHRQ, looked at 23 studies, 15 which were case control, 8 which were cohort, and again involved over 350,000 subjects. The risk of breast cancer was exceedingly low among every users, 1.08, and again, that degree of positivity could also be due to bias. It also was noted that the risk was noted with recent use, with risk decreasing over the time from when use stopped. Here, like the other studies we've already looked at, there was no effective duration of use. Overall, it was calculated the approximate increase in lifetime risk of breast cancer among oral contraceptive users was 0.89%, exceedingly low. What about breast cancer, particularly among women with BRCA1 and 2 mutations? Unfortunately, there's not a huge amount of data to look at this. There have been at least 5 studies, 3 case control, 2 cohort, which have involved a total of 4,500 subjects in 4 of the studies and over 65,000 person years in 1 of the studies, which were subjected, all 5 of these studies were subjected to a meta-analysis. The overall risk among oral contraceptive users was not statistically significant. That is, the odds ratio was 1.2, but the confidence interval bracketed 1, so it did not reach statistical significance. There was no evidence of an effective duration of use, but unfortunately the data was inadequate to analyze the effect of positive family history. What about progestin-only contraceptives, looking only at the progestin that's in birth control pills or in progestin-only contraceptive methods? Here also there are a paucity of studies with only 6 articles that have undergone a real systematic analysis, and this was conducted by Sampson and co-workers in 2016. 5 of the 6 articles reported no association between the use of any form of progestin-only contraceptive and breast cancer. And clearly, the author suggested that more rigorous study is needed due to small sample sizes, variations in progestins used and route of administration, and heterogeneity of study locations. Finally, we come to probably the most important study of recent note, and this is a large Danish registry study which basically examined 1.8 million women in Denmark aged 15 to 49, basically all the women that were in this age group when they started, and followed them on an average of almost 11 years. And during this period of 11 years, there were about 11,517 cases of breast cancer that were diagnosed. And the absolute increase in breast cancer diagnosis among current or recent users of any type of hormonal contraception was about 13 cases per 100,000 person years. So again, a fairly low rate. And this, in fact, equates to about one extra breast cancer case for every basically almost 7,700 women using any form of hormonal contraception for 1 year. But there are some nuances to this study, and here is data from Table 3 of the New England Journal of Medicine article that looked at this. And here they look at duration of use and look at the relative risk, looking at whether there was very recent use, use that is more than 1 year in the past, and use that was 5 to 10 years in the past. And they did show things that were different from what we've discussed before. Clearly, when you look at duration of use of 5 to 10 years or more than 10 years, particularly for women who were recent users and could be current users for that matter, you can see there was a modest increase in risk of breast cancer, 1.33 for use 5 to 10 years in duration, and more than 10 years for use. The risk was 1.52 for more than 10 years of use. So again, a duration effect which other studies have not shown. In addition, when you look at the risk of breast cancer related to when use stopped, particularly among the long-term duration users, that is 5 to 10 years, whether they had stopped within 1 to 5 years or 5 to 10 years, there still was a persistence of risk of breast cancer even though use had stopped. This is again among users of longer duration. Finally, the concern was, well, what about progestin only, and particularly levonorgestrel? And as circled here, you can see oral contraceptives that contain only levonorgestrel, no estrogen. There was almost a twofold increase in the relative risk of breast cancer, and this equated to about 47 events per 100,000 person years. So although the relative risk was elevated, again, the absolute risk was not huge. And sort of some concern was that the levonorgestrel releasing intrauterine system also showed a increased risk of about 1.2, but again, this equated to about 16 events per 100,000 person years. So again, first study to show that clearly progestin-only contraception may increase the risk of breast cancer. So how do we sort of look at this as sort of the bottom line? Does the use of some form of oral contraceptive increase the risk of breast cancer? Possibly some risk is increased, and possibly also there is a risk that increases with duration of use, at least based on this large database that was just recently published. Now, the reported overall low risk in all of these studies could be due to detection bias, that is, looking more frequently through regular exams, or could represent stimulation of tumors already present. And again, all of this has to be balanced against the reduced risk of ovarian and endometrial cancer, and this likely outweighs any potential breast cancer risk. What about the presence of a BRCA mutation? Does this affect the risk among oral contraceptive users? And there's no evidence that presence of a BRCA mutation significantly alters the risk. And finally, we get to what we last just looked at. Does the use of a progestin-only contraception pill, for example, or levonorgestrel-releasing IUD increase the risk of breast cancer? And clearly, this recent study suggests some increase in risk, but obviously confirmation is required in additional studies. When you look at how the MEC recommendations go relative to women with breast disease, you can see that only when women have current breast cancers or even past breast cancers, certainly the use of hormonal forms of contraception, and this would include even the levonorgestrel IUD, would not be indicated. And certainly the risk probably outweighs any benefit. But other than that, such as family history breast cancer, benign breast disorders, and so forth, no reason that any form of contraception should not be used. So let's switch to a different topic, and this is headache and hormonal contraception. Certainly, clearly we see many women who suffer from headache, and certainly the headache that's of greatest significance is migraine headaches. And the sorts of topics that I think I'll focus on is, can women with migraine headaches use combination hormonal methods? This has been debated for a number of years. How does one manage women with migraines during the hormone-free interval if you elect to use combination products? And can women with severe headaches that are non-migrainous use combination hormonal methods? Migraine headache, again, very common, affects about 43% of women in the United States, and clearly there is data that suggests that all migraineurs have some increased risk of stroke, and we'll show you some of those studies. Migraine without aura is the most common subset, but migraine with aura is more problematic because of its higher relationship to the risk of stroke. When you look at aura, 95% of aura episodes are visual, include things like flickering lights, spots, zigzag lines, pins, needles, and dysphasic speech. And there's a whole host of additional possible auras. And they must precede the headache and usually will resolve within 1 hour afterwards. In addition to migraine headaches, all of this interacts in addition with age, with combination oral contraceptive products, as we'll show you, and as well as smoking and hypertension. Here is, again, one of the large printout charts showing what the diagnostic criteria for migraine with and without aura. And again, as you read through this, in general, migraine attacks have to last somewhere between 4 to 3 hours to 3 days. Usually are unilateral and of moderate to severe intensity, often pulsating, can be associated with nausea, vomiting, even photophobia. So these are severe headaches. These are not the sort of tension headaches that go away with a couple aspirin after 30 minutes. In addition, there's a whole list here on the right side of what the aura is like, and this would be combined with the migraine that's described on the left. And you can see as you read through, there's a whole host of auras, symptoms, but in general, most will last for less than 60 minutes and can occasionally accompany the attack or may precede it. Relative risk of ischemic stroke with individuals with migraine headaches. That has been looked at in a number of studies, and the first big project to look at it was a meta-analysis of 14 observational studies by Eteminen. And it showed that the risk of ischemic stroke among all migraineurs, regardless of their type, was about twofold. When you looked among women with out aura, it was still relatively high and a little bit higher, at least in this meta-analysis, for women who had migraine with aura, such that the calculation was that the absolute risk of ischemic stroke among reproductive aged women is about 11 per 100,000 women years. And again, this is data from a different study done by Petiti back in 1996. When you look at migraine headache and risk of stroke, listed here are 2 case control studies as well as a database study on the far right. So if we look at the 2 case control studies, you can see as you add things, risk factors to individuals with migraine, you can see that the risks go up. So for migraine overall, the overall relative risk of stroke compared to someone who didn't have migraine was about 3 to 4-fold increase. You add in smoking and you go to a 7 to 10-fold increase. And if you add in birth control pills, although Chang did not show a substantial difference, certainly Tesorel did. almost 14-fold. And then if you have migraine, smoking, and combination products, you can see, at least in Chang's study, there is a substantial increase in the risk of stroke. Now, if we look to the far right, Lidegaard in his study was looking at cases of stroke per 100,000 women years. You can see when you had migraines with the use of combination oral contraceptives and women were aged 14 to 19, the overall rate of stroke was about 3.5 per 100,000 women years. When, however, the women were aged 45 to 49, again near the end of the reproductive lifespan, you can see there's a substantial increased risk in stroke. So again, age is a significant risk factor, particularly when combined with other risk factors for stroke. Here is, again, data from another study published in the American Journal of OBGYN looking at migraine with aura with and without oral contraceptive use. And we'll dissect this a little bit. When you look at migraine with aura, if you're a current oral contraceptive use, your risk of ischemic stroke was about 6. That is a relative risk of 6. Compared to, let's say, women not with aura who weren't oral contraceptive users, where you can see that the risk was about almost 1/3 of that. And so again, migraine with aura certainly is, and the risk of stroke is influenced by the use of combination hormonal contraception. When you look at women who have no aura and are users of birth control pills or are not, you can see here the relative risks are fairly similar. So it does not look like that when you have what sometimes is called common migraine or migraine without aura, it does not look like the use of oral contraceptive changes the risk of stroke among those women. And if you do elect to use hormonal contraception, and occasionally this is helpful for women, I might add, who have a menstrual migraine, to prevent the estrogen withdrawal or the onset of menstrual migraine, there are some strategies that have been suggested. One is to reduce the hormone-free interval to 3 to 4 days rather than 7 days if you're using combination products in a sort of monthly approach, or you can eliminate the hormone-free interval with continuous use of combination oral contraceptives, and that certainly seems to work. And the other approach is to start non-steroidals about 7 days before the onset of menses and continue it for 14 days. And at least in one clinical trial, this reduced the frequency, duration, and severity of menstrual migraines. So what's the recommendation of the US EMIC group in terms of contraceptive use for women with headache? In general, they point out that the benefits outweigh the risk with non-migrainous headache unless there's persistent symptoms after 3 months of combination oral contraceptive use. With migraine without aura, clearly their viewpoint is benefits outweigh risk in starting women less than age 35. However, the risk outweigh the benefits in women 35 years older who develop migraine headaches while on combination oral products or who have risk factors for stroke. So one has to be much more cautious in starting older women, particularly if they have risk factors for stroke or develop migraine headache after you start them. And overall, combination hormonal products are contraindicated in women who have migraine with aura. So to complete our analysis here, can women with migraine headaches begin use of combination hormonal methods? Yes, if there's no aura, and in general, if they're not over age 35. Can women with severe headaches that are non-migrainous use combination hormonal methods? Possibly, but again, discontinue if severity persists or worsens. Remember, even without migraine headaches, there is some risk of stroke with contraceptive use. How does one manage women with migraines during the hormone-free interval? Consider a continuous method or shorten the hormone-free interval. And finally, this is the diagram that's in the MEC chart, again showing that once you have aura, combination hormonal products should not be used, but of interest, progestin-only products are not contraindicated.